we're going to learn how to perform a venous reflux exam. Primarily, this tutorial will be on how to perform a normal venous insufficiency exam, because once you know normal, it will be easy to identify the abnormal. However, I will also be going over what venous reflux looks like and the appearance of varicose veins. But first, I'm going to discuss the mechanism of disease. Once you understand why you're performing an exam, it becomes 5 times easier to figure out how to do it, even when you come across difficulties during the exam. So don't skip this part if you want to fast track your ability to accurately perform this exam. So let's work backwards. Why are venous reflux exams ordered typically? Because of leg swelling and varicose veins. What causes venous reflux, which is outwardly evident in the leg swelling and the varicose veins? Incompetent venous valves cause this appearance. The valves act like one-way doors that allow the blood to return in the direction of the heart. When these doors become worn out, the blood doesn't move in just one direction anymore. It can move up or down, but many times the blood begins to pool in the feet, the ankles, and the lower legs. Then the blood may find new routes to hang out and pool in those areas. Thus, varicose veins are created. Also, genetics plays a huge role in the formation of varicose veins. So what causes these valves to become incompetent in the first place? One reason is venous thrombosis. When there is thrombus in a vein, those valves can't move for weeks or months on end until the thrombus resolves. So they're stuck. Once the thrombus is finally resolved and cleared, then those valves are stuck in place. They're frozen in place. Another reason that valves become incompetent is due to prolonged sitting and standing. This is why I wear compression socks when I go to work. Another reason is increased abdominal pressure. So with all this sitting, standing, the additional pressure, the valves say, look, I can only stand this high pressure environment for so long before I just give up. So a lot of the patients that have venous reflux are people with jobs or lifestyles where they are sitting or standing for prolonged periods of time. So we get a lot of barbers, cosmetologists or hairstylists, chefs, cooks, bakers, truck drivers, and office employees in our office to check for venous reflux. Also, I mentioned increased abdominal pressure. So pregnancy can provoke varicose veins in a lot of patients. Obesity can also cause strain on the body and cause venous insufficiency. Being older than 55 can contribute to venous issues. So just think about it. If you're at home sitting all day living the retired life and not being very active, you're not elevating your legs, then that can cause constant strain on those venous valves. The more a person with incompetent veins stands or sits around, the more gravity affects the blood flow and the more the blood pools around the lower legs. So the more the legs swell. Venous reflux occurs when the vein is distally augmented or otherwise provoked, which we will discuss later on, and the blood flow goes in the opposite direction that it is supposed to go. Typically with ultrasound, we demonstrate blood flow going towards the heart as being below the baseline on the spectral waveform. When you augment distally, in the case of venous reflux, however, the blood goes away from the heart and is shown above the baseline. Another way you can see whether a vein has reflux is by simply using color Doppler. You can turn on the color Doppler and watch the vein. If you have the color map set so that it will show blood flow going towards the heart as being represented in blue, then you can see if the blood flow is consistently blue or if it's alternating from blue to red. If the color flow is alternating from blue to red, for example with the patient's respirations or when you distally augment, then that patient has venous reflux. So now you should be able to understand why venous exams are performed and why we are going to do things the way we are. Normally, you would start a venous reflux exam by first checking for deep venous thrombosis. So I will not be going through that part of the protocol today as I've already done that video. You can check that out. However, I will highlight that as you're checking venous flow with the spectral waveform, you simultaneously want to check for reflux in the deep veins as well. So at the beginning of your spectral waveform, once the waveform starts, you want to augment distally and then leave the rest of the spectrum to evaluate for reflux. Also, it's very important that you understand how to steer your color box. Understanding the direction of the blood flow in your images is important in order to properly perform this exam. If you need help making sure that your color box is steered in the right direction and that your spectral waveform is matching correctly with the direction of flow, then definitely check out the Circulatory Skillset. That will break down everything for you. We do not need you misdiagnosing patients. Next thing that you want to keep in mind, patient position. The patients should be lying on their back with their knee externally rotated to evaluate the deep veins. That always opens up the veins, makes it easier to evaluate the vessels. Now, I usually perform this exam in reverse Trendelenburg. We'll further discuss some other positions later on, but I do the reverse Trendelenburg as an easier way to mimic the gravity that the patient experiences throughout their daily life. Remember, we discussed gravity and standing taking a toll on the veins. So we're going to replicate that during our exam to see how gravity affects the direction of the blood flow. Some of the most difficult things to do with this exam are to locate and to stay on the GSV. So I'm going to explain exactly how to do that, especially since someone asked me specifically to answer that question for them. So the GSV joins into the common femoral vein. It courses from the ankle to the medial calf, up the medial thigh, and into the common femoral vein. Many people get the GSV confused with the anterior accessory vein. And the posterior accessory vein is usually more posterior and medial to the great saphenous vein. So when you have the transducer in transverse and you're scanning in the groin from superior to inferior, and you see a vein that seems like it shoots off medially, that is usually the posterior accessory vein. Now the anterior accessory vein courses laterally on the leg. So it'll start in the groin and then sometimes it will course anteromedially along the thigh, or sometimes it will shoot across laterally and go along the outside of the leg. But the anterior accessory vein especially, it really depends on the patient. Some people have a very short anterior accessory vein, some have a long anterior accessory vein, and some people do not have an anterior accessory vein at all. Most are pretty short and they extend from the mid-thigh or the proximal thigh and then go into the saphenofemoral junction. So when you're scanning from superior to inferior and you see a vein course laterally in the groin, that's usually the anterior accessory vein. Now keep that in mind that it is going to appear on a different area on the image depending on which leg you are imaging. So it will be on the more so on the left side of the screen when you're scanning the right leg, and it will be more so on the right side of the screen when you are scanning the left leg. I know that can be confusing, but when you're actually doing it and you think of whatever is lateral on that patient's leg, then it will click. So one thing you will notice about the images that I have in this tutorial is that they flip-flop from one leg to the other. I just did my best to be able to present this information to you, but this shouldn't bother the teaching process anyways. I will just make sure that I'm clear in my instructions. So the saphenofemoral junction on the right side, as we have in this image, on the right leg, you're going to see this junction on the right side of the image because the junction will be medial on that leg, joining into the common femoral vein. However, it's going to be on the opposite side. On the left leg, it's going to be whatever is medial on that left leg, which usually shows up on the left side of the screen. Now, another way to identify in the great saphenous vein is the Egyptian eye sign. The great saphenous vein typically runs through the saphenous fascia. This fascia has a very characteristic appearance. The great saphenous vein It runs anterior to the muscular fascia and then posterior to the subcutaneous fascia, above the muscle, below the fat. So this will help you to identify the great saphenous vein when you see different branches coming in and out and you get lost on the vein. Just remember it's above the muscle, below the fat, typically. Another thing that you can do to make sure that you are on the great saphenous vein and not on another vein is by going all the way down to the ankle and identifying the great saphenous vein. This will be medial to the tibial bone typically. And for me, also, the great saphenous vein has thicker walls than different branches that feed into the great saphenous vein. It will have thicker walls. So go down to the ankle and follow the vein superiorly. Do that as many times as you need to. Whenever you get lost, just go down to the ankle and then try to follow the vein back up to the junction and make sure you're on the same vein the whole time. And also, branches or varicose veins will be closer to the skin. Now, the great saphenous vein sometimes can be extrafascial, meaning it comes out of this fascia and is more in the subcutaneous layer. In that case, I usually follow the largest vein and the one that is, again, that courses all the way from the ankle to the junction. Let's continue with the protocol, and I'm going to tell you a secret. You don't have to perform this exam just like me. You can omit or include whatever your facility allows. This is just how I perform this exam. So next we're going to go to the proximal great saphenous, the proximal thigh. And here, of course, like in my other tutorials, we have this little arrow, this white arrow representing the transducer, and then the point of the arrow representing the notch that the transducer is facing. So in the proximal thigh, we have our transducer, and this is what the proximal thigh great saphenous vein can look like. I measure the vein from outer to outer, have a dual screen with the measurements, and then on the other side, I have with compression. Simple image. I usually do my compressions all first, and then the spectral Doppler with my augments, and you'll see that later. So then we move the probe distally to the mid-thigh. Same thing, measure outer to outer with compression. Measure outer to outer at the distal thigh and measure with compression. Same thing with the knee, and then the proximal calf. Just following down the vein, just making sure you stay on the same exact vein. Now you do the same with the mid-calf and then the distal calf. And here you see this tibial bone. This GSV is right anterior to that bone. So now we're going to do our augments. Now, I just usually start right back where I was, where I have the probe, at the distal calf. So I make sure I have the vessel stretched out as long as I can, put the spectral Doppler waveform. Our providers like that angle correct on the vessel for whatever reason. But I have heard that it gives a cleaner spectral waveform, so we use it. You don't have to, of course. So distal augmentation. You can get a much better augment on the distal calf if you augment the foot. Of course, whenever you augment, you're going to be distal to wherever you have the transducer. And if there are varicose veins distal to the vein that you are interrogating, you want to augment those varicose veins. You want to augment those varicose veins. Why? Because they are holding a lot of blood. So the more blood that you can have rush up in the direction it's supposed to go, you can evaluate to see if those valves are really working or not. So we're going to move proximally to the mid-calf. Do the same thing. I would either augment at the distal calf or the foot here. Proximal calf, I would augment here at the mid-calf, or especially if there's some varicose veins hanging out in that area, I'll try to expand my hand as much to cover those veins and press down on those. Now we go to the knee a little bit more proximally. Again, distal augmentation. And when we measure, we are looking for some reflux, some return of the blood flow above the baseline. And this would be half a second or greater for the superficial veins, or 1 second or greater for the deep veins. If I see reflux that's 3/10 of a second, I'm not going to measure that. I just put the calipers right on top of each other and let it demonstrate 0. Some people will take one image, that short amount of reflux, just for documentation purposes. Now we move proximally to the distal thigh. You can see the valves in this image right here, and they seem to be working just fine. Now, a lot of times you will see a little blip right after you augment above the baseline. What I have been told is this is simply the valves closing. So this is not true reflux. I move proximally, do the mid-thigh, same thing. And proximal thigh, same thing. I would augment probably at the mid-thigh at this point. Also, if you want the patient to help you out some with your augmentations, especially in the lower part half of the leg, you can get them to pump their toes. I ask them to do this one time. For whatever reason, sometimes they want to, nope, just one time. Squeeze your toes and relax. That will augment for you. Now we're going to get into a couple more positions or techniques to see. So for the saphenofemoral junction, you want to place your sample gate right at where the great saphenous vein meets the common femoral vein, and then augment distally. Now we're going to get into some different maneuvers or techniques that you can try. You can ask the patient to stand and scan them that way. I will lower my chair as low as it can, lower the machine as low as it can, tilt my monitor towards myself to help with the ergonomics as much as possible, and then find the vein again, augment distally. It's a lot of hand-eye coordination, of course, and then also you can check with the Valsalva maneuver. What I will usually ask, you can do this different ways, but what I will usually ask the patient to do for the Valsalva maneuver is to take in a deep breath, hold it, and squeeze in your ab muscles. Then breathe and relax. So the moment that they take in a deep breath or when they squeeze in their ab muscles, if they have reflux, then you will see some blood flow above the baseline. And I will demonstrate that later on. If you don't see blood flow above the baseline when they are doing that, then there's no reflux with that maneuver. The IAC, the accrediting committee, they only allow you currently to use the Valsalva maneuver for the saphenofemoral junction and the common femoral vein to demonstrate reflux. Okay, let's move on to the anterior accessory vein. Hang in there with me. So, the anterior accessory vein, we see this one lateral to the great saphenous vein here. So measure anterior to posterior and use compression, and then also augment and demonstrate the spectral waveform, the small saphenous vein. So some people have a saphenopopliteal junction and some people do not. So you always want to scan that crease in the back of the knee superiorly and inferiorly to see if you see that vein diving down into the popliteal vein. If it does not dive down deep into that area and it simply continues going up straight superiorly, then that means that they have a thigh extension instead of a saphenopopliteal junction. So you can notate that on your report, that there is no junction. Now, some people will have a junction that joins into the thigh extension, as you see in this diagram here. If they have a junction, then I will image the junction in transverse and with the spectral waveform. If they do not, I simply skip that and go to the proximal calf. Get my measurements from outer to outer, and then with compression. Then I'll move distally to the mid-calf, image that, measure outer to outer, and then the distal calf, same thing. Then the proximal calf, then I'll move back up the leg, imaging the spectral Doppler waveforms. Now, as far as patient positioning with the small saphenous vein, I will usually have the patient bend up their knee, and I'll a lot of times flatten them out from the reverse Trendelenburg position because there's still the weight of gravity on the veins with the leg bent. This prevents their foot from constantly sliding down towards the end of the bed. So again, you can augment distally, distal calf, then the mid calf, augment distally, and then the proximal calf as well. Now, varicose veins. Let's see what these veins are looking like. So, this is a lot of times what the patient will come in looking like. They will have ropey, thick veins that you can see on the surface of the skin. They might not always be visible while they're lying down, but once they stand for a few minutes, you should be able to see those veins, and that will qualify as varicose veins when they're bulging, visible on the skin, and ropey. That's important, that they are actually ropey, tortuous veins. If you see varicose veins coursing laterally on the outside of the leg, most times, not all the time, these varicose veins are branches of the anterior accessory vein. So when you augment the anterior accessory vein, you want to be augmenting those varicose veins. Now, what do these varicose veins look like on ultrasound? On certain parts of them, you'll see multiple cross sections in one transverse plane. So I usually will take a transverse image and compress those to get the size of the vessels. Now, what does venous reflux look like on spectral Doppler? Finally, we get to this part. So you see, with this augmentation, you have the blood flow below the baseline. After the augmentation, you see blood flow above the baseline, and it's continuous. Now, venous reflux, it has to be continuous for you to be able to measure it accurately. Again, from my understanding, it would have to be greater than half a second for superficial veins, greater than 1 second for deep veins. If you go by something else, stick with that. Do whatever your facility tells you to do. Do not get in trouble because of me. I'm not going to have your back. I'm sorry. So, here's another example of venous reflux. You see the high velocity, and then it comes down. You see a little bit of up and down on the spectral waveform. That would still be reflux. I would measure from here to here. Now, here you can see where the reflux starts, and then you see some flow below the baseline, and then above the baseline. You cannot measure from here to here. You will be measuring just where the continuous reflux is from here to here. Now, this is an example of Valsalva, where there is reflux. So the patient takes in a deep breath, squeezes in their ab muscles, and then you see that blood flow above the baseline. Then you can measure that. Here's another example of negative Valsalva and then positive Valsalva. You should see the blood flow return below the baseline once the patient exhales. Would you look at that? That's it. So I hope this tutorial was helpful to you. If you have any additional questions, definitely let me know down below. I'll try to help. Check out my other tutorials and see you in the next video.